Hello students, in the today's session we will discuss pharmacology of drugs for the management of hyperlipidemia or hypolipidemic drugs. Now in order to understand pharmacology of hypolipidemic drugs, it is very essential to first understand physiology of lipid transport. Triglycerides and cholesterol esters are the lipids that circulate in blood. Both triglycerides and cholesterol esters are insoluble in water, and thus these lipids are circulated in blood in the form of lipoproteins. Now when we talk about the structure of lipoproteins, lipoprotein globule is made up of central hydrophobic core consisting of triglycerides and or cholesterol ester, an outer hydrophilic shell which is made up of phospholipids, free cholesterol and apoproteins. Now when we talk about the functions of triglycerides, triglycerides break up into free fatty acids and provide energy to body. Unused calories are again stored as triglycerides in body tissues. One of the main tissue in which triglycerides are stored is the adipose tissue. Cholesterol is required for the synthesis of cell membrane. It is required for the synthesis of cholesterol ester, bile acids and vitamin D. Cholesterol is also a precursor of steroidal hormones like estrogen, progesterone, testosterone, cortisol, aldosterone and many others. Now let's talk about types of lipoproteins and their transport. Lipoproteins are transported by three pathways: exogenous transport, endogenous transport and reverse cholesterol transport. Exogenous transport is the transportation of dietary lipids, while endogenous transport is the transportation of lipids synthesized by the liver in the body. Now let's first talk about exogenous transport of lipids. Now dietary lipids, that is the lipids derived from the diet, are absorbed in the intestine as chylomicron. Chylomicron is a lipoprotein, and these are the biggest of all the lipoproteins. The size of a chylomicron ranges from 100 to 500 nanometer. This is the structure of a chylomicron. The hydrophobic core consists of triglycerides, 90% triglycerides, about 90% triglycerides as shown in the red color, and very small amount of cholesterol ester as shown here in the green color. The hydrophilic shell is made up of free cholesterol, phospholipids and apolipoproteins, mainly apolipoprotein B48, apolipoprotein C2 and apolipoprotein E. And these chylomicrons, they circulate in the blood. Now endothelium bound lipoprotein lipase is an enzyme. So endothelium bound lipoprotein lipase hydrolyze triglycerides which are stored in the hydrophobic core into fatty acids. So triglycerides which are stored in the chylomicron, they are converted into fatty acids by the enzyme lipoprotein lipase. Now these fatty acids, they pass into muscle cells and the adipose tissue. In the muscle cells, these fatty acids are utilized as a source of energy, while in the adipose tissue or in the fat cells, these fatty acids are reconverted into triglycerides and stored. So after the breakdown of triglycerides, these chylomicrons, they shrink in size, and now these chylomicrons are termed as chylomicron remnants. Now size reduces from 100 to 500 nanometers to about 30 to 50 nanometers. The size of a chylomicron remnant is as small as 30 to 50 nanometer. And since triglycerides of chylomicrons have been broken down, now This chylomicron remnant, it contains mainly cholesterol ester as shown here in the green color and small amount of triglycerides as shown in the red color. And these chylomicron remnants, these are engulfed by the liver. This is how chylomicrons circulate in the body and provides energy to the muscle cells, and they provide triglycerides to the adipose tissue. Now let's talk about the endogenous transport. Now VLDL, that is a very low density lipids, are the lipoproteins synthesized by the liver. Now the VLDL consists mainly of triglycerides as shown here in the red color and small quantities of cholesterol esters. Diameter of VLDL is about 40 to 80 nanometer. This VLDL, it circulates in the blood, and again endothelium bound lipoprotein lipase hydrolyzes triglycerides in VLDL to fatty acids, and these fatty acids are utilized by the muscle cells as well as by the adipose tissue. So now the VLDL remnants are termed as to be the IDL, that is the intermediate density lipoproteins, and these IDL, they contain comparatively less quantities of triglycerides, and the size of the IDL also reduces, and the size is about 30 to 35 nanometers. Now about half of the IDL, that is the intermediate density lipoproteins, are engulfed by the liver, while the rest 50% they circulate in the blood. Again, endothelium bound lipoprotein lipase, they hydrolyze triglycerides stored in the IDL and convert them into fatty acids, and now these IDL, they become LDL. There is further reduction in the levels of triglycerides. So now the LDL, it mainly consists of cholesterol ester and only very insignificant quantity of triglycerides. So LDL primarily consists of cholesterol ester. About 60 to 70% of LDL is engulfed by the liver, while the rest of the LDL circulates in the blood and reaches the peripheral tissue. Now these peripheral tissue, the cells of these peripheral tissue express LDL receptors, and the LDL, that is the low density lipoprotein, it binds to these LDL receptors which are expressed on the surface of peripheral tissues, and this results in the uptake of LDL by the peripheral tissues. Now these peripheral tissues, they utilize LDL for the synthesis of cell membrane, for the synthesis of bile acids, vitamin D, or for the synthesis of steroidal hormones, as we have already discussed. Now excess LDL results in the deposition of LDL in the body tissues, which is termed as the xanthomas, and excess of the LDL also gets deposited in the coronary blood vessels, resulting in the production of atheroma, that is atherosclerosis, which is the main risk factor or which is the main cause of coronary vascular diseases. Now let's see what is the reverse cholesterol transport. Reverse cholesterol transport is mediated by high density lipoprotein. Now cholesterol is released into blood after degradation of membranes from the peripheral tissues, and this cholesterol it is collected by HDL, and then this cholesterol is esterified, and HDL transports this cholesterol to the liver, and therefore a reverse cholesterol transport is a transportation of cholesterol from the peripheral tissues to the liver. HDL is termed as to be the good cholesterol. Now let's see what happens if the levels of VLDL rise in the blood. High levels of VLDL, that is the very low density lipoproteins or triglycerides of more than 150 milligram per deciliter, increases the risk of pancreatitis. And the risk factors associated with the pancreatitis are genetics, that is the family history of hyperlipidemia, intake of alcohol, then poor diet, that is the diet that is rich in sugars like ice creams, sweetened coffee drinks, sporty drinks, energy drinks, they should be avoided as the body converts excess glucose into triglycerides. Then foodstuffs like cakes, pastries, and food items with saturated and trans fats also increase triglycerides. Increase in the level of VLDL or risk of pancreatitis is also caused because of the obesity, and metabolic syndrome like diabetes is one of the causes of high triglycerides and the risk associated with pancreatitis. Now, high LDL leads to development of lipid deposits in the body tissues like skin, tendons and subcutaneous tissues, and these lipid deposits are called as xanthomas. And further, high levels of lipids is one of the most important risk factors for the diseases like ischemia, myocardial infarction, stroke, and the risk factors which are associated with high LDL are poor diet, that is a diet which is rich in saturated and trans fats, obesity, lack of exercise, and diseases like diabetes. And now let's talk about the lipid profile, that is a desirable or optimum level of lipids which should be present in the body. Now, total serum cholesterol, it should be less than 200 milligram per deciliter. LDL cholesterol should be less than 100 milligram per deciliter. HDL cholesterol in male should be 40 milligram per deciliter or higher than that. HDL cholesterol in females should be 50 milligram per deciliter or higher than that, and triglycerides should be less than 150 milligram per deciliter. Now let's discuss pharmacology of hypolipidemic drugs or drugs for the management of hyperlipidemia. These drugs reduce level of lipids and lipoproteins in the blood. Now, as we all know, increase in the levels of triglycerides or increase in the levels of very low density lipids results in pancreatitis, and increase in the level of cholesterol esters or LDL cholesterol increases the risk of cardiovascular diseases. So these are the drugs which reduce the level of triglycerides and or cholesterol esters, and most of these drugs also increase good cholesterol, that is HDL. So let's talk about the classification of these drugs. First category of drugs are HMG coenzyme A reductase inhibitors, commonly termed as statins. For example, lovastatin, simvastatin, atorvastatin, pitavastatin. Now, these are the first choice drugs to reduce LDL cholesterol levels. And second category of drugs are the bile acid sequestrants, also termed as bile acid resins. For example, cholestyramine and cholestyramine. These drugs reduce the level of LDL cholesterol. However, these drugs are not clinically useful because of the poor patient compliance. Now, third category of drugs are the lipoprotein lipase inhibitors, and these are also termed as PPAR alpha activators, that is peroxisome proliferator activated receptor alpha activators, and also commonly termed as fibrates. For example, clofibrate, gemfibrosol, benzofibrate, fenofibrate. Now, gemfibrosol is a first line drug to reduce the levels of triglycerides, and these drugs are beneficial in preventing episodes of acute pancreatitis. Now, next category of drug is the nicotinic acid. It is lipolysis and triglyceride synthesis inhibitor. It reduces the synthesis of triglycerides in the liver. Now, however, due to adverse effects, due to the adverse effect profile that is caused because of the use of nicotinic acid, use of nicotinic acid, or commonly termed as niacin, is restricted to high risk cases. Now, last category of drug is the sterol absorption inhibitor. For example, acetamide. This is a novel drug. This drug inhibits intestinal absorption of cholesterol, and it is usually used as an adjuvant to statins. Now, let's talk about the pharmacology of HMG coenzyme A reductase inhibitors, commonly called as statins. Drugs like lovastatin, simvastatin, atorvastatin, and many more. Now, let's first talk about the mechanism of action. Now, as we all know, cholesterol is synthesized in the liver. Now, statins are the drugs that competitively inhibits the enzyme HMG coenzyme reductase. And by inhibiting this enzyme, these drugs, they reduce the synthesis of cholesterol in the liver. Now in the liver, HMG coenzyme A is converted into mevalonate, and mevalonate is further converted into cholesterol. Now HMG coenzyme A reductase is a key enzyme that regulates the rate limiting step, that is the conversion of HMG coenzyme A to mevalonate. And these statins, they competitively inhibit the enzyme HMG coenzyme A reductase. So the main mechanism of action of statins is to reduce the synthesis of cholesterol in the liver. Now, since there is reduction in the synthesis of cholesterol in the liver by around 20 to 50%, this results in compensatory increase in the LDL receptor expression on the liver cells. And the LDL in the plasma binds to these LDL receptors on the liver cells, and this causes increased uptake of LDL from the plasma into the liver cells. And further, there is increase in the catabolism of IDL. More and more of IDL is converted into LDL. And these drugs, they also reduce synthesis of VLDL, that is, they also reduce synthesis of triglycerides in the liver. Now, talking about the lipid profile, statins reduce level of LDL cholesterol by 20 to 55%. They increase HDL by 5 to 15%, and they reduce triglycerides by 10 to 35%. Now, when we talk about adverse effects, one of the main adverse effects of statins is the disease of muscles called as myopathy. And myopathy is characterized by red, wimpy, that is very weak, inflamed muscles. Now, rhabdomyolysis, that is breakdown of muscle tissue, has also been observed. However, this is a very infrequent side effect. Now, statins can also produce mild hepatotoxicity, and there can be increase in the levels of serum transaminases, and therefore it is essential to monitor the liver functions. Now, when we talk about the indications, as we all know that we have already discussed, these drugs, they reduce the level of cholesterol. These drugs, they reduce the level of LDL. So these drugs are the first choice drugs for the treatment of primary hypercholesterolemia, and these are found to be very useful for the treatment of secondary hypercholesterolemia, which is caused because of secondary problems like diabetes, nephrotic syndrome, and other problems. Now, let's discuss pharmacology of lipoprotein lipase activators, that is fibrates, the drugs commonly called as fibrates. Drugs like gemfibrosal, benzafibrate, fenofibrate. Now, these are the drugs that primarily reduce the levels of triglycerides. Now, it is very important to understand, it is very important to note that these drugs, that is lipoprotein lipase activators, they reduce the level of triglycerides in the blood. They reduce the level of VLDL in the blood. Now, let's talk about the mechanism of action. The primary mechanism, the main mechanism by which these drugs reduce the level of triglycerides is by the activation of peroxisome proliferator activated receptor alpha. Now, peroxisome proliferator activated receptor alpha is a gene transcription that regulates receptors expressed in liver, fat, and muscles for synthesis of lipoprotein lipase. So, by activating PPAR alpha, these drugs, they primarily increase synthesis of lipoprotein lipase. Now, as we have already discussed during the physiology of lipid transport, lipoprotein lipase is an enzyme that is responsible for the breakdown or hydrolysis of triglycerides. Triglycerides are broken down into free fatty acids. So, increase in the synthesis of lipoprotein lipase causes increased catabolism or increased breakdown of triglycerides. Now, increased breakdown of triglycerides results in reduced level of triglycerides in the blood. Now, apart from that, these drugs, they also increase oxidation of fatty acids. Now, because of increase in the oxidation of fatty acids, free fatty acids are not available for the synthesis of new triglycerides. So on one hand, they are responsible for the breakdown of triglycerides. On the other hand, there is reduction in the synthesis of new triglycerides. So overall, these drugs primarily reduce the levels of triglycerides or VLDL in the body. Now, these drugs also enhance expression of LDL receptors on the liver cells. Now, increased expression of LDL receptors on the liver cells results in increased binding of LDL to these receptors. So, more and more LDL from the plasma binds to these LDL receptors on the liver cells, that causes increased uptake of LDL by the hepatocytes. This results in fall in the levels of LDL in the blood, or fall in the level of cholesterol in the blood. Now, apart from this, these drugs also decrease hepatic synthesis of triglycerides. As we have already seen, as we have already discussed, these drugs increase the oxidation of fatty acids, so they reduce the circulating free fatty acids, and because of the reduction in circulating free fatty acids are not available for the synthesis of new triglycerides. Now, when we talk about the effect of these drugs on the lipids, fibrates, they reduce the levels of triglycerides or very low density lipids by 20 to 50%. These drugs, they also reduce the level of LDL or cholesterol by 5 to 20%. And these drugs increase good cholesterol, that is HDL, by 10 to 20%. And when we talk about the adverse effects, first type of adverse effects produced by these drugs are GIT distress, for example, loose motions. Then these drugs, they are also found to produce skin rashes, body ache, eosinophilia, headache, blurred vision, impotence. Myopathy is also seen, but the symptom is very uncommon. Indications, as already seen, these drugs, they reduce the level of triglycerides. Gemfibrozil is a first-line drug for reducing the level of triglycerides, and these drugs, since they reduce the level of triglycerides, since they reduce the level of VLDL, they prevent episodes of acute pancreatitis. Now, let's talk about the pharmacology of bile acid sequestrants, also termed as bile acid resins, for example, drugs like cholestyramine and cholestyramine. Now, one thing to remember, that these drugs, they reduce the level of LDL cholesterol in the blood. Now, mechanism of action, these drugs are the basic ion exchange resins or polymers. So, these drugs are the polymers. And since these drugs are polymers, they are neither digested nor they are absorbed in the body. And these drugs are only excreted as such from the body, they are not metabolized. Now, these drugs, that these polymers or these resins, they bind to the bile acids. Now, once they bind to the bile acids, they lose their function. They are not able to perform their function. They are not able to emulsify the fats. So, binding of bile acids to these polymers prevent enterohepatic circulation of bile acids, and the bile acids are simply excreted from the body. Now, since the body requires bile acids for the emulsification of fats, more and more cholesterol in the liver is used up for the synthesis of new bile acids. So, there is enhanced hepatic conversion of cholesterol to bile acids in order to produce new bile acids. Now, since the liver cholesterol is used, excess of the liver cholesterol is used for the synthesis of bile acids, this causes fall in the level of cholesterol in the blood. So, these drugs, they reduce the level of cholesterol or LDL in the blood. Further, there is increased expression of LDL receptors on the liver cells. Now, since the expression of LDL receptors is increased, more and more of LDL from the plasma binds to these LDL receptors on the hepatocytes, and there is increased uptake of LDL by the hepatocytes. This further reduces the levels of LDL in the blood, and there is enhanced clearance of plasma LDL. So, overall, these drugs, they reduce the level of LDL cholesterol in the blood. Now, talking about the effect of these drugs on lipids, these drugs reduce the level of LDL cholesterol by 15 to 30%, and they increase HDL, that is a good cholesterol, by 3 to 5%. Now, when we talk about the adverse effect, these drugs are not popular clinically because of the profile of adverse effects produced by these drugs. Now, since these drugs are polymers, they are unpalatable. The doses are very large, and these large doses are very inconvenient for the patient. There is very poor patient compliance. And since polymers are not digested, not metabolized, not absorbed, this results in problems like flatulence and gastrointestinal symptoms. And once these drugs they bind to other drugs, they inhibit the absorption of many other drugs. So these are some of the adverse effects, and because of these adverse effects, bile acid sequestrants are not popular clinically. Indications, as we have already seen, these drugs they are found to reduce the level of LDL cholesterol in the blood. Now let's talk about the pharmacology of nicotinic acid, commonly termed as niacin. Now one important thing to remember here, that niacin, it primarily reduces the levels of triglycerides or VLDL in the blood. Now mechanism of action, nicotinic acid inhibits lipolysis in the adipose tissue. Now, as we have already discussed during the physiology of lipid transport, lipolysis means breakdown of triglycerides. So, nicotinic acid inhibits the breakdown of triglycerides, and since triglycerides are not broken down, there is reduced availability of free fatty acids. Now, since there is reduced availability of free fatty acids, there is reduced synthesis of triglycerides in the liver, because liver require free fatty acids for the synthesis of triglycerides. So, overall, nicotinic acid inhibits lipolysis and reduce the availability of free fatty acids, thereby reducing the production of triglycerides or reducing the production of very low density lipids in the liver. So overall, this drug reduces the level of triglycerides in the blood. Now, when we talk about the effect of nicotinic acid on the lipid profile, it reduces triglycerides by 20 to 50%. It reduces LDL by 15 to 25% and increases HDL by 20 to 35%. Now, talking about the adverse effects, now one of the major problems associated with the nicotinic acid or niacin is the large dose. Large doses are needed for the hypolipidemic action, and these large doses are poorly tolerated. So, the patient compliance is not there. Now, talking about the adverse effects, niacin causes cutaneous vasodilation. It produces marked flushing due to the release of prostaglandins, and this flushing, it could be minimized by the use of sustained release tablet, and it can also be reduced by the administration of aspirin before the administration of niacin, as we all know that aspirin inhibits the synthesis of prostaglandins. Another problem of this drug is the dyspepsia, problems like vomiting and diarrhea. Nicotinic acid can also lead to dryness and hyperpigmentation of skin. It can produce liver dysfunction and jaundice, hyperuricemia and gout. Now, coming to the indication of nicotinic acid, as we have already seen, it reduces the level of triglycerides. But because of the poor patient compliance, because of the adverse effect profile, use of nicotinic acid is restricted to high risk cases. And it is the drug that reduces the level of triglycerides, and therefore it is indicated in hypertriglyceridemia, and it controls pancreatitis, which is caused because of the increased triglycerides or which is caused because of the increased VLDL. Now let's discuss the pharmacology of sterol absorption inhibitor, that is the ezetimibe. This is a novel drug. Now, this drug inhibits intestinal absorption of cholesterol and phytosterol. It reduces absorption of dietary as well as biliary cholesterol. Now, how this drug inhibits absorption of cholesterol is by interfering with cholesterol specific transport protein, that is NPC1L1 in the intestinal mucosa. So, overall, this drug it reduces the absorption of cholesterol, thereby reducing the level of cholesterol or LDL cholesterol in the blood. However, it cannot reduce LDL cholesterol level by more than 15 to 20%, and therefore the drug is a weak hypercholesterolemic drug. When we talk about the adverse effects, this drug can produce reversible hepatic dysfunction. It can produce myositis, but that is rare. Lipid profile. Ezetimibe, it reduces LDL cholesterol by not more than 15 to 20%, and therefore it is indicated in mild hypercholesterolemia, and it is normally prescribed in those cases when the statins are contraindicated or when the statins are not tolerated, and it can also be used as an adjuvant to statins in order to reduce the dose of statins. So overall, ezetimibe reduces the level of LDL cholesterol in the blood by about 15 to 20%. So this is all about the pharmacology of hypolipidemic drugs used for the management of hypolipidemia. Now, if this is helpful to you, kindly like, subscribe, comment and share this video. Thanks for watching this video.